Good morning. Peter Gertz here. I'm a psychiatrist. Let's talk about trauma, psychological trauma in psychiatric patients, which is very common in general. Trauma, psychological trauma in the general population is very common, and it's even more common in the life histories of psychiatric patients. And it can be connected with many psychiatric issues, psychological issues down the road. Um, and what we're talking about, for example, are combat experiences like Vietnam combat veterans. Um, and another major aspect is physical, sexual, or emotional abuse or neglect in childhood. And the DSM-5, or any of the DSMs, at least any of the recent DSMs, focus on symptoms. They do not focus on the life histories of patients, um, or on genetics for that matter. So the DSM focuses on symptoms, not on what's underlying the symptoms, whether it's genetic or psychological experiences, traumatic experiences during people's lives. So that's one thing to look at or understand, I think, about the DSM, is that it does not look at what's underlying people's symptoms, at least in general. It does not look at the life history, it does not look at the genetics. But of course, these things are very important. That does not mean the DSM does not have its place, but it does not look at what's underlying people's pain or suffering. So many diagnoses, excuse me, can be connected with trauma in childhood or in later life. And some diagnoses, the trauma is actually part of the diagnostic understanding and criteria. For instance, dissociative disorders very commonly have an aspect that includes a history of abuse, whether in childhood or later in life, usually in childhood. And similarly, borderline personality disorder, most of those patients, most patients who've been diagnosed with borderline personality disorders, the vast majority have a history of abuse. And that actually has helped me over the years when approaching people who have been diagnosed with borderline personality disorders and have those features. They can be quite challenging to interact with. But one thing that helps me a lot in interacting with people with borderline personality disorder is to remind myself of the aspect of pain that's underlying that, a history of being abused, neglected in childhood, etc. And if you visualize these people as a very young child crying out for help, that can help, at least that helps me approach these patients with equanimity and not be, how should one say, not be frustrated by these patients in interactions. So I think it's important to remind ourselves when we approach patients with borderline personality disorder where these people are coming from. You know, they're not maliciously trying to upset us. They're very troubled themselves and in pain themselves, emotional pain. Of course, PTSD, the trauma is built into the diagnosis, the aspect of trauma, but also many other diagnoses. People with many other diagnoses in psychiatry have a history of abuse. Many people with depression have a history of abuse, with bipolar disorder, with schizophrenia. Conduct disorder, it's pretty much, or at least is very common in a patient with conduct disorder. It's almost like, how should one say, you can almost take it as a symbol. So let's say a young boy starts punching other young children in class, and before that he was fine. more than likely he was exposed to some kind of violence, either directly himself or witnessed, his father beating his mother, something like that. So if a little boy starts acting like that, punching other boys or punching other children, that pretty much can mean, or at least often does, that there was violence recently in that person's life. And conduct disorder, of course, very often develops into antisocial personality disorder, and these are adults then with that same background. So one could say that the diagnoses we give people, one could put it this way, the diagnoses we give people are often labels, or one could even say euphemisms, for people with histories of very challenging experiences, abuse, combat experience, etc. And that does not mean the diagnoses don't have their purpose. Of course they have their purpose, for instance, in doctors communicating with each other, so we know what we're talking about. But again, there is that aspect that there are things underlying the diagnoses that the diagnoses don't necessarily refer to. So if someone's been traumatized, especially in childhood, sexually, physically, they can have difficulty with boundaries, and that, it's never about blame or fault, of course not, but that difficulty with boundaries can lead to more vulnerability for abuse later in life also. So often people repeat those experiences of abuse in childhood, in adulthood, again and again, unless they get into psychotherapy and look at the pattern of what's going on and understand that, and then are able to shift it. So these things can be very insidious, very common, and very, very troublesome unless they're addressed. And what we're talking about in general is beliefs based on abuse in childhood. So let's say a little girl witnesses her mother being beaten by her father repeatedly growing up. She may develop the belief that later in life that's going to happen to her. She may see that as an experience that just is going to happen, that just is part of life because of her own experience as a child witnessing that. And not infrequently, girls who grow up like that may then have the experience of men coming into their lives, or they may let men into their lives. Again, it's never about blame or fault, but they may let men into their lives who are abusive physically towards them. So these patterns can repeat themselves, and psychotherapy can interrupt that. It's very difficult to interrupt that without psychotherapy. So again, our beliefs, which can be subconscious or unconscious, about things that happen to us, especially traumatic experiences, can lead to us repeating those experiences or being more vulnerable to those experiences. Again, I want to stress, it's never about blame or fault. It's not someone's fault that they were abused as a child or exposed to combat. It's not about that, but people tend to be more vulnerable to letting abuse into their lives if they, from childhood, have the beliefs that can be subconscious or unconscious, that no matter what they do, they're going to be mistreated, abused, their boundaries are going to be violated. So these things, unfortunately, are very common. As far as treatment, it seems important to base that on the individual preference of the patient. Some people are doing okay, in their opinion at least. They do not want to address any trauma in their lives. They do not want to talk about it. And that, in my opinion, needs to be respected. Medication, of course, can help with symptoms. It generally cannot get to the roots of trauma, of course. But some patients are satisfied with that. They are fine with taking medicine to help with symptoms. They do not want to address the roots, and again, I think we need to respect that. There are methods aside from medication, of course, to to address the psychological part. For instance, people in various ways can process the experience of trauma, for instance, with visualization and feeling the experience during a psychotherapy session. That can be quite traumatic in itself, though, so the patients really need to be willing on a given day and ready on a given day to do that, to engage in that. EMDR is used, eye movement, desensitization and reprocessing, and ultimately where patients can get to, which is a big help to them, is to not repeatedly, or not as frequently at least, go back into the past to those traumatic experiences, but be able to be more in the moment, be more present, and enjoy their lives. And again, these things can be very difficult long term. I remember I was sitting in my office with a Nazi concentration camp survivor in her 80s, and she was sitting on the edge of the chair, and her body language was saying she felt like she was about to be hit. She was full of tension. So if these things are not dealt with, they can be very difficult long-term issues. All right, thank you very much. Bye.